neoadjuvant therapy has become critically important currently, both in the evaluation of patients for routine management, but also especially for clinical trials and evaluating new drugs. In order to be able to compare the results from one trial to another, from one patient to another, to make decisions about the success of that neoadjuvant treatment, one needs to have standardized, well-characterized ways of evaluating the residual disease burden, if there is one, or assessing a complete pathological response. If this is done in a standardized way, it allows one to make conclusions comparing one trial to another or one patient to another. If it's not done systematically, then it can be problematic. An approach to evaluating residual cancer burden was developed at MD Anderson. They do it very thoroughly and very carefully. It's well described. There are good correlations with disease outcome after neoadjuvant treatment. And I would say this is the standardized way in which we should all try to do this because it's well described, well characterized. So residual cancer burden measures disease that remains after a treatment in the breast at the site of the original tumor, in the tumor bed. It also determines if there is disease present, how much is present at that original site, and if there is also disease that's spread to the lymph nodes in the region, how many of those nodes are involved and what is the size of the largest node. And there is a mathematical calculation that's performed to integrate all of that information into a score that determines whether there's no disease left, minimal, a moderate amount of disease, or substantial disease. And those outcome levels are correlated with the long-term disease-free survival of the individual or their overall survival. Currently, pathologic complete response is used as a surrogate endpoint for evaluating drugs for approval in the treatment of breast cancer. So the evaluation of this with pathology is a critically important step.